A very good morning, everybody. I'm here to present my clinical study on management of patients with orbital sarcoidosis. So, as we know, sarcoidosis is a multi-system disorder. Most commonly, it generally affects the lungs. Ocular involvement, as such, is generally very rare, and if we do see any cases, always in the form of a uveitis. So, I did a literature search, and the number of large case series are very few, and especially there are hardly any other than few small case reports from India. So, my study was on the clinical features and management outcomes of orbital and adnexal sarcoidosis. It was a retrospective study. We studied all patients who present with sarcoidosis for the last 10 years at 2 tertiary eye care centers. We collected the demographic details, the clinical features, what is the treatment given to each patient, and the management outcomes. So only patients who presented on histopathology with non-caseating epithelioid granulomas were included, and we made sure that we ruled out all other causes for epithelioid granulomas. All patients underwent imaging either in the form of an MRI or CT. HRCT tests were done for all patients once histopathology confirmed sarcoid, and serum AC levels were done. So our study included 21 patients with a mean age of 47.7 years. We saw that we had a female preponderance, as all seen in literature. Right and left eye were equally involved, but 5 patients had a bilateral involvement. The mean duration of symptom onset was 2.45 months, and we noticed that the most common presenting feature was an upper eyelid swelling, followed by lacrimal gland enlargement, a palpable mass, proptosis. We had one each of a sac swelling and a conjunctival nodule. One patient had a bilateral lacrimal gland involvement. None of our patients had intraocular, so anterior segments were normal, and there was no past history of tuberculosis. Imaging was done in all except 2, the reason being one presented like an acute dacrocystitis and the other had a conjunctival nodule, hence imaging was deferred in these 2 patients. We found lacrimal gland to be involved in 4, whereas 8 patients had a diffuse or had an orbital soft tissue mass, of which 3 had a diffuse lesion, the remaining had well-defined lesions. Extraocular muscle and conjunctiva, you can see, were just 1 each. So based on the clinical features and imaging findings, the most common initial diagnosis was either an IOID or a lymphoproliferative disorder. Since these patients had already undergone treatment elsewhere, hadn't responded to treatment, or there was some kind of a clinico-radiological mismatch, we went ahead with surgery, of which incision biopsy was done in 16 patients and an excision biopsy was done in 5 patients. All patients had characteristic non-epithelioid, non-caseating granulomas confirming diagnosis of an orbital sarcoidosis. HRCT chest was done in 19, of which we found that bilateral lymphadenopathy hilar was seen in 11, whereas 8 patients did not have any pulmonary involvement, and none of our patients had a past history of sarcoidosis for which they were taking any treatment. Serum angiotensin converting enzyme levels were raised in 10 patients, whereas lysozyme and calcium were normal in these 11 patients. So in accordance with the pulmonologist, we treated these patients. Oral steroids were given to 7 patients. 5 patients who did not respond with oral steroids were started an additional oral methotrexate. The mean duration of treatment was around 2 to 4 months for these patients. Observation was done in 3 because the mass was completely removed. 6 of our patients were lost to follow-up post-surgery. So mean duration of follow-up was 7 months, and in these 7 months we found the outcomes. Complete resolution was seen in 13 patients and a partial resolution was seen in 2, and none of our patients had any recurrence. So these are some of our patients. You can see this is patient 1 who's presented with the bilateral lower lid swelling, and MRI also shows an ill-defined mass and conjunctival nodules, which was shown to be sarcoidosis. The second patient is similar with the lower lid mass, and this is a patient with a bilateral lacrimal gland involving both the palpable and the orbital lobe. Here's a patient with a conjunctival nodule, and this is hilar lymphadenopathy. This patient was treated with steroids, and you can see this was only treated with topical steroids and a complete resolution. So sarcoidosis affects the lungs. Eye is seen to be involved in 25 to 60, and most often they say that eye involvement occurs secondary to a systemic sarcoidosis. So when we see the ophthalmic manifestations, it can involve any part of the eye. Starting from the eyelids, it can involve the sclera as well as the optic nerve in the form of neurosarcoidosis, orbit, and even intracranial involvement can occur. This is a patient, one of ours, who had a pure extraocular muscle involvement with tendon involvement. But clinically, when the patient presented, it looked very much like a active thyroid eye disease. And similar reports have been published in literature where sarcoidosis presents mimicking a thyroid eye disease. There's a patient who presented with an acute dacrocystitis, and we assumed it to be acute DAC, but she did not respond to analgesics, and hence we imaged and we found that she had a soft tissue mass in the medial canthal region, and she was diagnosed with sarcoid. Similar reports have also been published. It's important to keep this in mind because it's one of the important causes for a failed DCR, which is sometimes missed. So there's always a controversy in terms of diagnosis. Many authors believe that you can only diagnose an orbital sarcoidosis if a patient has a systemic sarcoidosis. But there are also debates against it, because there is published literature where not all cases of an orbital sarcoid on histopathology have a systemic involvement. There's a large case series of 30 patients where they noticed that only 11 had orbital sarcoidosis past history, 8 were simultaneously diagnosed, and 9 never developed sarcoidosis in follow-up. It's very important to do systemic workup for all patients to rule out a systemic involvement. So treatment for sarcoidosis is very straightforward. It's generally steroids as a first line management. Most patients resolve with oral steroids. In well circumscribed lesions, an intralesional steroid can also be given and shows very good response. In those who don't respond to steroids or those who have intolerance to steroids, you can start them on steroid sparing agents, and methotrexate works really well. If not for methotrexate, mycophenolate and cyclosporin. There's a literature review that we did. We found most studies had lacrimal, but ours had soft tissue involvement was more common. As to conclude, it is a rare disorder, but you need to keep it in mind as a differential. And so treatment in these patients generally has good outcomes, but it's important to have a long-term follow-up. Thank you.
I have a question. What was the dose of oral methotrexate?
So we started based on the body weight, madam, 1 milligram per kg body weight. So based on that, we slow tapered it over 2 to 3 months.
Over 2-3 months?
Yes, ma'am.
So you gave it like on daily basis, or was it?
On daily basis, oral steroids.
No, I asked about methotrexate.
Oh, methotrexate. Methotrexate was given once weekly, and it was only given for patients who are not responding to steroid.
How much?
So methotrexate, we started 500 milligram and once week, 50 milligram, sorry, and then we tapered it down.
It was recommended by the Oculoplasty.
No, not by Oculoplasty. We sent to the pulmonary. Yeah. We never give immunosuppressants at our place. We always refer to pulmonologists and they start. Yes. Yeah. They were monitored. Correct.
And what this study has added new to the existing literature. Out of us, we knew the upper limb swelling is very common, the treatment is much added, and the study population is also very less.
Yeah. But generally it's very rare. So in 20, so such a long duration, we only had 20.
In India, the tuberculosis is very less.
Yes. Most often they're misdiagnosed with tuberculosis. Yeah. Yes, correct.
We should add something like new forms of treatment, but has been included in Western population. Then we should add something to the.
Yeah, most often we found everywhere lacrimal gland. Ours was more of a soft tissue involvement, where most people diagnose it as an IOID. So we need to keep this in mind. Yes, sir. Yes, sir. All the cases.
So, what was the method to take muscle biopsy in case which had extraocular muscle abnormality?
Yes, sir.
And also in case where there was acute dacrocystitis?
Yes, sir. So the muscle biopsy, we took the from the inferior oblique. So we expose the muscle and we take it from the orbital part, the muscle belly, and we take it along the long axis of the muscle.
Inferior oblique was also.
Yes, yes, sir. And in the other patient, because we suspected that there was some pathology for the lacrimal sac, we opened up the entire sac. So we just left a small frill of tissue, and the rest of the entire sac granulation tissue was removed completely. DCT, but again, a modified DCR, the entire sac tissue was removed and then created an osteum. Yeah, more like a DCT. Yes, DCT, yes, sir.
The uniqueness of your study is in its number, 21 patients.
Yes, sir. So in India, as such, there are not any cases reports of that.